Welcome back into the Concord TV studios for another episode of Community Conversations. And we do have a serious topic today because we wanted to talk about Lung Cancer Awareness Month. And we're lucky to have an expert in the field who is able to spend time talking to us about what we need to know about lung cancer. This one hits close to home for me. My own grandmother passed away in the 90s from lung cancer, and almost everyone likely knows someone who has passed away or suffered from lung cancer. So I'm really fortunate that we have Dr. Black here from Concord Hospital. Thanks for coming into the studio.
Sure.
And this is your first time in the studio as well,
Yes,
right?
it is.
Under the bright lights. So why don't, real quick, maybe just give us just a quick, like a little bit of a background, a little bit about yourself and your role at Concord Hospital.
Sure. So I've been in Concord Hospital working since 2012. We moved here after my training. My wife is a New Hampshire native, so returning her home from exile was very appreciated.
Yeah.
Being close to family, and I've really focused my career on focusing on lung cancer staging, screening, minimally invasive procedures to diagnose and confirm the answer, and then collaborating with our colleagues. In addition to our routine general pulmonary clinic or asthma and all the rest of the lung disorders come to visit, and then we rotate to the intensive care unit where we have time to do all the best care we can in that very sick, challenging population.
Right. So in terms of lung cancer awareness, I mean, we know it's such a deadly form of cancer. Why is this education and the awareness about lung cancer? Give us some additional kind of background on why that's so important to engage with the community about.
Sure. So lung cancer is exceptionally common, and it is far more lethal than it should be. And annually, we typically have more than 220,000 cases per year in the country of new lung cancer diagnoses, over 120,000 plus lung cancer-related deaths per year. And if you take that comparing to other cancers we care very much about, and for very good reason, breast, colon cancer, prostate cancer, there are more deaths from lung cancer than any of those combined per year. So that is a tremendous burden to our population,
right.
And also with the benefit of early detection, we have a chance to deliver more cures with long-term survival being expected.
So is it the aging population in New Hampshire that increases risk as well, just being at a higher age?
Yeah, higher, older age, longer smoking history, even if former smokers remain at risk, although the risk can improve with time. The glories of living in the Granite State, we do have more radon in areas that are closer to outside the mountains, but often it's a smoking population and aging are some of our most obvious risk factors.
What's with the radon prevalence? Give us maybe just a little bit more. I'm not as familiar with.
Right, it's an additive risk factor, particularly strong with smoking being in the mix. So I know people are concerned about radon exposures, and I certainly don't pretend to be a radon mitigation expert in,
Sure.
in that field.
Yeah.
But it adds to the additive risk in our community.
Yeah. And so you talked about early detection. Is there sort of a trend where people just aren't being screened enough for it? What is the screening process? Give us a little bit of that.
Sure. So lung cancer screening has been a guideline from national societies for more than a decade at this point. Back in 2013, I believe, the U.S. Preventive Service Task Force endorsed screening, and expert societies additionally have joined in. And then there was a revision in 2021 to expand and actually simplify the aging the population that can be at risk. So we have some of the slides if we could add that onto defining that group.
Yeah.
So ages between 50 and 80 at this point, who are either current or former smokers if they quit within the past 15 years. And smoked at least 20 pack years in their lifetime. So a pack year is kind of a complicated measurement to think about at times, and people often struggle with that. But it's simply if you smoked a pack a day on average, to the best of your recollection, for 20 years or more, that's 20
okay.
pack years. Or if you smoked 2 packs a day times 10 years, that's also 20 pack years.
Okay.
So it's someone's best recollection. No one can recall what they did the last 40 years precisely every single day.
But people can ballpark knowing their own life history.
You essentially have to, because there's no way to do that with any better precision.
Actual metrics. So if you get tested earlier for lung cancer, if you catch it earlier, like other cancers, the general concept is that you have the treatment you catch it earlier, you have a higher success rate of...
Correct. And then the treatments are based on the staging, and staging will be tremendously impacted on when you detect the illness. A stage 1 lung cancer, you would expect local treatments based on either a surgery, if that's viable, or non-surgical treatments like radiation treatments, which also have a very high cure rate. But most folks get diagnosed with their lung cancer, both in our area, nationwide, and worldwide for that matter, at a stage 3 or higher, which means cures are harder to come by. They can be provided, they do exist, but they are harder, and often because they come in with symptoms. And if we think about lung function more generally, we have so much lung capacity that we rarely even tax on a routine day that you have to compromise a lot of that lung function before someone starts feeling short of breath or has that nagging cough.
So by the time you feel the symptoms, it's already been plaguing you potentially for a little while.
Correct.
Other cancers can be like that too, right? Like pancreatic, you might not feel all, immediately, and then all of a sudden you feel that stomach pain or something like that.
It's the value of finding things at an early state where you can offer a treatment that really impacts long-term survival. And for aggressive cancers that have that but long pre-symptomatic process, colon is another example, mammography for breast cancer another example, you can change the course of what someone would have felt.
So what would someone expect if you go in for a lung cancer screening? What could someone expect, sort of what actually goes into the screen? Is it just kind of like blowing into a tube to test lung capacity, or is it an actual, some sort of MRI or something, or what?
No, actually it's a CAT scan. It's a very simple CAT scan. It does not require any IV contrast, so people who have hard to find IVs or don't love the sharp object needle poke, that's not part of the test. The scan can take just really a few seconds. It's probably 20-30 seconds of actual on the gantry time. It is very, very quick. And then the radiologist would be reviewing the scan and would essentially assign one of 4 categories in terms of kind of punchline of what to do with the results. And with 1s and 2s, really just saying keep doing annual screening. If someone remains eligible based on the eligibility plan, where 3s and 4s, there's a something, but we know that many of those little nodules, as they're called, are going to be unimportant. That's the false positive rate, which we do have to counsel patients about. We don't want to scare people unnecessarily when 99 out of 100, that little small nodule is going to be unimportant or even temporary. Could be some phlegm or a resolving infection or something, or even a little souvenir from an infection decades ago that will never be important. But that does generate a lot of concern. So we at our hospital, we then facilitate a discussion with one of our pulmonary providers for those scenarios. Then 3s and 4s have more workup. Often surveillance imaging is the most common follow-up plan, a CAT scan either 3 months or 6 months. If things are really more concerning at the time of that assessment with that specialist, then we include other testing like PET scans, or talk about biopsies, or if it really is a high enough concern, well, that's when our multidisciplinary review starts happening, when we have chest surgeons, medical oncologists, radiation oncologists, pathologists, all the people that you want to give the best counsel they can to the patient to proceed next.
Right. So the screening sounds very effective. It works well. So why are there issues with screening rates being so low? If it's effective, why are we seeing screening rates?
Sure. Just to talk about what screening rates were happening, if we could bring them on the second slides, if we could. Nationwide, screening has been an ongoing struggle for lung cancer screening. It's thought some of that is lack of awareness, it's lack of availability, it's lack of systems to provide the screening and guarantee the appropriate follow-up. And there is in some scenarios, people feel that the lung cancer they get after a long-term smoking was in some way their fault, and they have a lot of emotional baggage that goes with it, which it really isn't justified, but it is part of the multiple reasons. So in the U.S., annual screening, if you look at American Lung Association data, they would say that Rhode Island leads the nation in screening their population based on the guidelines, but they get 30% or so of their population screened. And if we're taking a test in high school and you got a 30% on your test, you're going to be grounded for the next 6 months.
Not good.
It's not, and that's leading the nation. Massachusetts is slightly better than New Hampshire in this regard, but they're in the 20s. New Hampshire, for our population, we're screening 19% of our eligible population.
Wow.
So that clearly is an underserved focus. Just for comparison, just to keep what screening areas do exist in other fields, mammogram screening for women for breast cancer, which is certainly a very important need. Yep. It's screened much higher. Medicaid data from New Hampshire, yep, for eligible enrollees, it's between 50 to 75% of eligible patients are getting screened for mammogram, yep, for breast cancer, which that number is still not anywhere where optimal would be, but it is still vastly superior to what we're achieving with lung cancer screening.
And this might come up a couple times through the rest of this interview, but preventative care and also the benefits of if you catch these things early, it's better for our population's health, it's better for our healthcare system, it's, probably I would imagine financially better to catch something early and do earlier treatment than dealing with later on down the line.
Yes, so clearly all of this should start with smoking cessation and good healthy behaviors over our lifetime. That is a tremendous part of this, because the cancer that never happens is the easiest one to treat.
Yep.
But if we have to deal with a cancer that does exist, yes, treating it for cure at an early stage is superior. And in the states or in the regions that have been able to impact the screening population, there's been a very clear shift from stage 3 and stage 4 lung cancers to stage 1 lung cancers with improved survival. So again, American Lung Association has improved lung cancer 5-year survival rates that exist, which our numbers for our diagnoses are comparable to the national average, which is respectable, but we would love to strive for better.
Yeah.
States that have better screening rates, not too surprising, have better 5-year survival rates.
Right.
That's just how it works.
Yeah, that's logically that tracks, that mm-hmm, one leads to the other. You had mentioned some of the different options for folks who receive a diagnosis, the different team that, that can be called in to deal with treatment. What's some of the technology, if we dig into a little bit? We've heard so much about some of the different exciting new technologies, which I imagine are available at Concord Hospital, mm-hmm, when it comes to treatment.
So first is you have to start with good proper staging of the patient. There's 2 questions we have to answer for a patient, assuming cancer is a true diagnosis. We have to figure out someone's resectability, which is a way of thinking about what's their stage. Is this an area that the surgeon can take out safely as a process? And that's often based on the stage. Stage 4 is it's spread to other body parts. Stage 3, it's if they're a larger tumor or it's involved the lymph nodes in the middle of the chest. Stage 2 is a medium-sized area in the primary thing or lymph nodes in the same side. Stage 1, it's a smaller thing and no lymph nodes involved. So just giving that kind of context.
Sure. Yeah.
So once someone has, we need to know that information, and that requires imaging and biopsy areas. So to enrich our imaging yield, a PET-CT scan is a very common study. It's essentially a hybrid study between a CAT scan, which gives anatomy and structure and location imaging, with metabolic activity, or as I described to patients, how busy are those cells? And it's essentially radioactive sugar water in kind of its essence, going to parts of the body that are growing, dividing, repairing. Some normal things light up like a light bulb, like brains light up like a light bulb because they eat sugar water. Our kidneys put this stuff into our urine, so our urinary bladder is bright. So there are things that are normal. But if you have a growing abnormality that shouldn't be there, that lights up on a PET scan, odds are it's much more highly likely to be a cancer.
Yep.
Not guaranteed, but that's more likely.
Yep.
And then biopsy routes, if it is a very, very small cancer on the edge of the lung and has a high imaging risk to be a cancer, and the person has good lung function, good body health overall, there is often a good value to going straight to the operation to take it out and make a diagnosis in one trip. That's its most efficient. However, that's a fairly small niche market, so to speak. So often we do need to have a biopsy in some way prior to starting treatment.
Right.
Because you can't do that minimally invasive surgery diagnosis thing in one step. So to getting into the lung, there's really 2 ways into the lung to biopsy the lung. One is outside in, which is a historic standard, is a CT-guided biopsy, which our institution and across the country has been a historic standard, which can give very high yield into the target, but will come with somewhere historically between a 15 and 20% chance that the lung collapses down, something called a pneumothorax.
That as you're trying to get that biopsy sample,
Correct. The lung collapses down because they're going through the balloon lining of the lung. Kind of thinking about this, kind of how the process happens. However, of course, only around half of those issues do you have to do something to fix it. So you find a thing, but isn't necessarily important. But it's still a risk we would like to avoid.
Right.
And if staging often depends on lymph node involvement, that biopsy through the chest wall can't assess the lymph nodes. So you have to think, is my imaging enough, or do I have to go back in through the inside-out approach to biopsy the lymph nodes separately? So doing two procedures has two procedural risks and perhaps is less efficient and has higher risk. With newer technology, which we and other centers can provide, do a bronchoscope approach to go in for the inside-out, biopsy the lung from the inside out, and in the same setting, same trip to the anesthesia, biopsy all the lymph nodes that are accessible.
Okay.
So it can be a much more efficient process.
Instead of having to do two different of these operations, it's done in one.
All in one trip to the operating room.
Yep.
And the reported and experiential pneumothorax complication rate is much lower, somewhere in the order of 5% complication rate. And again, not all those you have to actually do anything about. Again, we're not going through that procedure doesn't go through the lining of the lung. You should expect less popping of the balloon.
Right. But the concept, you're still trying to just get a sample, enough that can then be extracted and then tested to see if it's cancerous.
Correct. You want to prove it really is the cancer you think it is, because we have other things that are not cancer. We have generally a pretty good idea that something is, and there are well-validated predictor models to give some patient a % likelihood of a cancer. We can use those numbers, but they are not perfect.
Right.
And if you're going to subject someone to losing maybe 20% of their lung capacity with a surgery, you really do like to know, should I do that or not?
Right. So if you're fairly certain that what you pick up during a screening is just, like you had mentioned, something residual or something that, like a recovering infection, if you're fairly certain that's what it is, then you're not going to go the operation route.
Correct. If there's a really good chance that it's not a cancer or anything important, surveillance is often the most common pathway, which doesn't need any biopsy risk whatsoever.
Which means just continue monitoring symptoms.
You would have a CAT scan over time, 3 or 6, or even just staying in the 12-month screening plan. It's for those times where we need to proceed it with some kind of confirming diagnosis. That it makes a lot more sense to get all the information in one trip as best as you can. No, there'll always be a role for going through the outside in, depending on someone's anatomy and their story, and that gets to the multidisciplinary review we want to make sure we're providing for our patients.
Right.
So you have surgeons and oncology doctors and radiology doctors all working together
and treat it case by case, which is important too.
Correct. So you can bring all that expertise to bear.
So some of this sounds pretty scary for folks, I'm sure, who, anytime we talk about these difficult discussions, it's scary. What would you say to folks who, especially might be in a at-risk population about, is this something to be scared of? I know, but putting that very plainly, but something to be scared of, or how do you sort of weigh that in terms of having precautions, being prepared, getting screenings, but that fear level people might have of this?
Right. So there's a lot of concern that the lung cancer always has to be a terrible thing. And of course, we don't want people to have lung cancer. We want smoking rates to go away, and we want people to be a healthy population because we'd want folks to be thriving for all their duration. But screening is quite valuable because it finds those things that you can fix. And there's also other benefits to screening exams besides even just finding the lung cancer concern. We find their emphysema in their lungs that they never had to ask about. We then have the opportunity to say, oh, you're really short of breath. What things are limiting you? Oh, it's hard to walk to the mailbox, or you can't walk to your grandchild's soccer game, and that really is a bother. Let's dig into that and measure how we can make this better for you. We could get, talk about medicine therapy, pulmonary rehab therapy, get people really thriving. And also, we're taking a whole picture of the whole chest, so we see the heart. We see a static photograph of the heart. We see the the heart artery calcifications,
Sure.
and other things that can then give use to help guide all the medical care that can be applicable. And again, many of our little nodules we find, they don't have to be scary. They need to be thought about. They need to be, cautiously approached one by one, but they don't have to be scary. For those patients that I really think have a unimportant nodule, I even try to allay their fears about what the phrase that's been in our culture for years is, "My doctor found a spot on my lung." And that phrase really generated some negative, scary connotations to it. And my own perspective on that is that phrase started when we didn't have CAT scans. Decades ago, all we had was an X-ray, which is a much less sensitive tool. So it's only going to find larger things. And if your doctor found a spot back in 1970 on your X-ray, chances are it was going to be much more important. With our CAT scan technology being such it is, we can find 3 and 4 millimeter nodules that we could never possibly find on an X-ray. So we can find these things, we can address them. If it progresses something we need to deal with, it's something we can have a chance at cure. But those little nodules, I actually tell patients, Mr. X, Miss Y, you have let's call it a dot. Let's call it a dot, because that almost makes it sound comical. It helps to alleviate some of those fears. We still do our standard approach. We still are cautious with follow-up. We do all the things we can, but we try to decrease some of that burden.
Yeah. Yeah, that's great. And when it comes to the actual treatment, obviously we're very familiar with the radiation treatments, so the kind of traditional. With new technologies, there's what I heard about this SABRE. It's kind of an acronym. I don't really know anything about it, but it's supposedly a better or a newer type of treatment compared to traditional radiation.
Correct. So radiosurgery more broadly can be delivered in very high treatment doses to a very small volume with a very high chance of cure over a very short duration. So for patients who cannot or should not have a surgery for their early stage lung cancer, our radiation oncology doctors do a fabulous job with their treatments. And the treatment is typically a 4 or 5 day treatment session, delivered outpatient with a very high cure rate and generally very good tolerability. So people tolerate quite well. Yes, there's always concerns about side effects, and the doctors are very thoughtful about counseling about such.
Side effects being like nausea?
For radiation, for that, mostly it's fatigue and cough as common things, and and a little bit and some skin changes to the skin overlying the treatment area. But generally, those are the predominant things, and it can be quite well tolerated. And that's in the early stage scenario. Other significant advancements in the lung cancer field and treatment-wise have mostly made their impact on later stages over time, particularly with using the genetics of tumor types to derive specific medicines that can starve those cancer cells of that kind of abnormal signal, so that makes them grow. We very commonly look for those. To be truthful, they're not exceptionally common to find them, but we always look. They're more common in non-smokers or never smokers. They're more common in women than in men. So there are things that we always look for because if we find it, it's very actionable data. And then as an additional tremendous add-on over the last several years is the use of immunotherapy to activate someone's immune system to treat the cancer. Because in some way we can all think that the cancer grew because our immune system didn't take care of it in the first place. So that's been a tremendous add in both in the basically stage 2 and beyond areas, and active growth of research of how best to add that in. So it gets to there's so many different ways to treat, which gets to why we need different expertise to kind of offer the best counsel we can to our patients.
Different experts coming together, looking at the specific case, what stage you're at, and what treatment course to go through.
And which sequencing of staging. Do you do A before B or B before C? Sometimes they're concurrent, so you're doing chemotherapy and radiation at the same time. Then it's followed by the immunotherapy. So there's a lot to go into it, but that's why we have those discussions where we sit down collectively and talk those cases through. We communicate collaboratively across the different groups, even if we're not physically in the same office space. If we are, that's wonderful. And as part of one thing that we've learned with the complexity of the care and having all those different places for patients to go is the invaluable resource that a nurse navigator can be.
Yeah.
Because you can have some person where they say, okay, I'm going to go to 12 different places, it seems like, I have all this stuff to do. Where's my one person I can reach out to? And that's a tremendous benefit to answer questions, help assure follow-up, dig into what are someone's resource needs, getting them tied in with social work, nutrition. It's a tremendous benefit to our population to have that resource.
So that nurse navigator, tell us a little bit kind of how that role functions and what they do.
Now, different institutions have them function in different roles. For us, it's particularly on the in-treatment and in that catchment area between where multiple specialties are overlapping. So medical oncology, radiation oncology, and surgery are all kind of together on the care. So it's a great help to call patients, connect with them, see them in their clinic visits, make sure they're getting their questions answered, they have their taxi vouchers or whatever they need to get to their treatments. It's a great way to help support the patient.
To help keep things seamless, because you're right that when you're meeting with
Right.
so many different specialists and different appointments and meetings, that you have someone who is supporting you and keeping everything kind of.
Correct. It is a tremendous benefit, and we wish we could clone all the nurse navigators who do such great work in lots of fields. Lung cancer is not unique to that. Having
Sure.
navigation post-hospital discharge for someone's hip fracture or other things are all tremendously valuable to have that point person where folks can say, this is really who I can rely on to answer the questions and see me through this complex story.
Yeah, they sound like remarkable individuals because there's some organization, good communication skills, empathy to the patients going through these situations. It sounds like customer care, customer service, but also they have to understand the hospital system and navigating through that.
Correct. I'm very happy to joke, but not entirely in joke, that all doctors need good supervision by nurses. It just makes a lot of the world work better.
So that you can continue doing your job well, right? That's the whole, what makes the system work well. So for our audience watching who, we probably have current smokers out there, folks who maybe are hearing this and going, okay, or know someone who, it seems like if you quit smoking, that's your best chance of reducing risk. That if you just start taking steps now, it's better than not taking steps at all. What are some of the resources that folks should look into?
So there's a tremendous amount of options, but it often just starts with the patient. I ask my patients this kind of simply in my visits, even if there's no lung cancer concern at that time, and I ask the intentionally playful/provocative question of, "Oh, Mr. X, you smoke. Oh, when are you quitting?" Just kind of playful and joking about it, just to kind of prompt them to start thinking about it.
Yep.
And then saying things like, "Well, what good do you get out of it? Like, all the bad stuff. Doctors annoying you, it's expensive, all the rest of the stuff, there's bad health things, but what good do you get out of it?" And people often struggle, saying, what actually do I get good out of hurting myself? And that helps facilitate the conversation. And then people need to start a plan. For different people, that first question will vary about what they can then be advised on. Some people who say, well, I'm not quitting, I'm not, and they're like, well, I don't need to make a plan and teach you how to quit when you have no interest in doing that. And it's just an ongoing discussion of, we really want you to be healthy, we want you to live a long time, we care about you, and start there. But for people who are looking to make a plan, primary care doctors around the world are helpful resources to quit smoking. There's both nicotine replacement products that can be available if that is really part of their strategy. There are medications, prescription medications that can decrease cravings. We have a smoking cessation clinic through Concord Hospital, which is a fabulous resource to people who just need to sit and talk through the story more to generate how do I change my environment and take away those triggers that prompt me to smoke.
Yep.
And then there are statewide resources as well. The New Hampshire Quit Line. New Hampshire Quits is essentially all it is to help people quit smoking, which is through the state. And then national-wide resources, American Cancer Society, American Lung Association has significant resources to add as well. So there's innumerable options to quit smoking. but it often just starts with someone realizing that this is not what they want, and they think they can change.
Right.
And folks can. It is hard. It is hard to quit smoking.
Yeah.
I have people who are tremendously symptomatic. They're struggling to breathe. I've people who are on oxygen, people who have burned themselves while smoking on oxygen, people have burned themselves while smoking on oxygen a second time.
Oh my God.
It
It's
is
an addiction.
It's tremendous. It is very hard. And but it's have to start with, well, this can be better. We really want better for you. We want you to want better for you, and we need to find ways to help this improve, and then provide resources and guidance to do that.
Well, I think that's a perfect way to sum it up. I hope that's what our audience takes out of it today is being willing to give it a try, to quit smoking, and to know the resources available. I think that's a great thing. Do you have any other final thoughts? Just sort of like, what should we take away from this episode today? There's so much that we've talked about over 30 minutes here, but what's maybe one final takeaway?
Sure. I guess the summary is we want smoking to go away in terms of our health consequences. If someone you or someone you know you love is smoking, knowing that there are resources that can help them quit. There's tremendous benefit both on the lung health, cancer health, and cardiovascular health that can be performed for people who have been long-term smokers or are still smoking. Talk to your primary care doctor about screening options. Then figure out the best of your ability, how long have you smoked and what do you think you've averaged. Very commonly, you'll be eligible for screening. If so, find ways to get screening started. And then once you get that wheel started, just like people get colon cancer screening or annual eye exams, it just becomes normal to go look for things you can intervene on, and knowing that down the road, if there is a finding, that's important. Lung cancer treatments have significantly impacted ability to treat with good tolerance, can be good outcomes, but we need to start with just starting at the beginning with preventing them by not smoking and finding them early.
Yeah, that's a great takeaway with prevention, and thank you for joining us in the studio, Dr. Black, and for your expertise and for all that you do. We appreciate it quite a bit, and not too bad in the bright lights. You've done pretty good here, so thank you for joining us on the show. Thanks for tuning into Community Conversations. We're always looking for more story ideas. We like to talk with different nonprofits, different community organizations. Today's topic about National Lung Cancer Awareness Month was so important, and we look forward to having more conversations here in the studio next time. Thanks for watching.